Hello, everyone. Thanks for tuning in to this week's episode of the Health Me podcast. Remember to leave a like and subscribe so you don't miss any updates. This week, we had another amazing discussion with a fellow physical therapist to discuss ways the profession can change for the better. In fact, our next guest has been working on several ways to change the profession of physical therapy, but none more important to her than diversity. Our discussion today will highlight areas where diversity can play a huge role on clinicians and patients, and how we can relate to one another through empathy and acknowledgement of each other's biases. Later, we get into what our guest primarily works in, and that is clinical education. As a result, we will cover some of the differences that exist within clinical care and academia, how these differences map the profession, and much more. To wrap things up, we get into a very fluid part of the physical therapy profession, and that is student education. Within this topic, we go over where students struggle the most on clinical, how to prepare for clinical care, and how academia shapes students for the future. Links for everything for my guests and what we talk about today will be in the show notes, and timestamps for each part will be provided as well. Please enjoy my conversation with Dr. Moyo Tillery. As a director of clinical education, part of your job is to ensure students are getting the most out of their experience at the university. However, within physical therapy, there is a point where students venture out into the clinic for the first time and with hopes to find clinicians that are similar to them. Unfortunately, within physical therapy, there happens to be a lack of diversity in some respects. So when or how did you start to notice this trend for students or perhaps yourself?
Yeah, thank you so much for that question, Mike. It was pretty early for me in my journey into a career in physical therapy. I had actually never heard of physical therapy until I was going into my senior year of college. So, relatively in the pipeline, you would call that late. And I do attribute that to the fact that there are not a lot of minorities in physical therapy who, like me, are Black female, and I just had never met one until the summer before I went to physical therapy school. And so I think that's part of the reason why we're having this issue with diversity is a little bit of both. So young children, young adults, there's not a good representation and role modeling for individuals who may look like us and who may look like them in the profession. And so diversifying physical therapy goes beyond, the issue of identity. It's being able to sort of picture yourself existing within a profession that already exists and is thriving. And so if there are no members of the profession who look like you, it just makes it a little more difficult to picture oneself in that profession.
And certainly for students, when it is a point in time when you're trying to learn as much as possible. I mean, you are. I remember being a student myself. I don't know if you remember. It's just all you want to do is soak up as much information as possible, and obviously learn from people who are doing it. And if there's a point when you get out there and you realize there's no one out there doing it who looks similar to you or doing it exactly the way that you want to, I'm sure it can feel like not unmotivating at the very least.
Sure. And I think isolating is a really good way to describe it. If we take it to the next level, sometimes you attend conferences and you can feel a little bit isolated because, again, for the same reason, there are not a lot of people in the conference who may look like you. So it can be pretty isolating. I agree.
And we hear this word often, diversity, and especially more recently, it's been something that a lot of people talk about more and more. I wanted to kind of get your perspective as to what diversity means to you, and maybe like your definition or
Sure.
what would you classify diversity as?
Yeah, I love that question because it means so many different things to so many different people. I think based on their own experiences, for me, it's truly the point where people with different ideas and experiences kind of culminate together in a common space. And what happens is one person's experience influences the other, and it starts this domino effect of just a general increase in awareness about really truly the beauty of diversity, what everyone else brings to the table.
And overall, I guess where does physical therapy lack in their in diversity? I mean, physical therapy is still kind of a new profession in the sense that where we're still kind of laying the foundation and the groundwork of like the whole profession as a whole. And I guess like where are there stigmas or maybe just areas where diversity isn't as prevalent?
Yeah, I think there are probably several areas where, just within the profession, we're looking into a lack of representation in general. I think it's easy to sort of immediately associate that with race, just given the history of the country. And then just looking around, there is a lack of racial representation, but to your point, Mike, I think there are stigmas about, that could extend into gender and age. I think I as a manual therapist, sometimes patients will look at me and say, "Are you sure you're strong enough to, move my leg or position me like, you need to?" And they may not use those words, but they insinuate, a female therapist may be physically weaker than a male therapist. Or they'll ask me if, "Hey, you want to ask him to do it if I have a much larger student, with me?" And so for me, it's a point to educate the patient. PTs come in all shapes and sizes, and we're trained to manipulate body parts to get the outcome we're looking for. So it's more of a teaching moment for myself and even the student in the room. But to further extend that is even students and new grads, right? They could be pictured, there's a perception, a patient bias that maybe they're not as experienced, and they'll associate that with a lack of knowledge. And we know that's not true because our new grads bring so much to the table. So, race is one class, but I think we can look into different biases do exist within gender and age and level of experience. It's multifactorial, I think, is a good way to summarize that.
And was you, as a student, was that the first time that you had experienced maybe stigmas or disparities or things where perhaps, like you had said, that somebody had seen you come up to them as a student or even as a physical therapist and be like, "Are you sure you're able to do this?" Was that kind of the first time that you really started experiencing some of the stigma?
Yeah, I don't know, Mike. I think honestly, it would be a few years into my practice as I was sort of coming into myself as a physical therapist. As a student, a lot of what I witnessed was essentially being questioned about who I was in the clinic, what role that I came to play. And so as a student, it may be because you look younger. And so they associate it with, "Oh, you're just the secretary or you're the PT tech or you're the scribe." I was asked once if I was the scribe for the medical doctor. And I was like, "No, no,
Like
I'm a physical therapist and I'm here to treat you alongside my supervisor, or I'm a student physical therapist here to, conduct your treatment alongside my supervisor." So again, looking at it like this is a moment to educate our consumers about physical therapy students may look like me and that's okay. So yeah, my experience with it has varied throughout my career.
and how have you been able to maybe overcome some of these issues or things that you see? I mean, you still have to treat the patient, right? It's not like you can be like, walk
Mhm.
out, well, like, "See you later," I'm not going to treat you because you're being a jerk. I guess
Yeah,
how have you been able to overcome that mentally as a continuing practitioner?
yeah, it's tough. I This experience is personal. I think everyone's journey is a little bit different in sort of the mental resilience it takes to kind of push forward. I will say honestly, I think by the point, or at least for me, by the time that I made it to PT school and was out in clinic, I'd had to overcome a lot already. And so it was sort of just another, I had practice on kind of shaking it off and then, processing maybe a little bit later instead of in the moment, because I understood the consequences would be compromising patient care. And a lot of that sort of came from personal experience, but mentorship is key. I had PTs in the clinic who would pull me to the side and say, "Hey, you did a good job, not letting that affect you." And, we'll share stories about when it happened to them. Not necessarily normalizing the experience, but sort of just being empathetic and kind of guiding me through the moment. And so that's been incredibly helpful.
And I'm sure it's been helpful because you also see students as well. And I'm sure this has allowed you to kind of take difficult moments and make it a, like, there are still people who are, think this way, or maybe they're not even
Mhm.
aware of their own biases. And perhaps this is a moment where you can identify that there's going to be challenges throughout the road ahead. And these are things you're going to have to overcome, because being completely blind to that, I think will be it won't be a great thing to do. You're going to have to address these things as you go along.
Definitely.
And as we try to implement more diversity within physical therapy, it's great to talk about it, but implementing it is a completely different other thing. And so, is implementation as easy as discussing the topic of diversity?
Of course it is. Most certainly. Yeah, I think that there are probably more seasoned therapists than myself who can share their story of, how far back these initiatives really date. This is not new work. I
Hmm.
did it when I was in PT school. Someone did it before me. And so initiatives are plenty. There are many, and everyone is working towards this goal, somewhat in silos. I think if we, become a little more cohesive in these efforts, they may stick. I think the approach is starting to shift to more sustainable initiatives by looking at the systemic issues versus, individualistic approach to trying to solve such a large issue. I think historically it was you had one champion for DEI, and there was one person, and there was this one event. And so when that person, graduates or retires, or, whatever the case that leads to attrition, then the initiative dies. And so I think what we're seeing now is things like hiring folks who that's all they do is weave DI through systems. It makes it a little bit harder to quell the initiative. It just kind of births itself in many different ways. And I think that's great. I think we're on the right track.
Well, I don't want to sound ignorant in asking this, but I'm hopeful just to maybe just put it out there for people who may not understand they have biases, and is part of this diversity training to obviously identify people who are blatantly being specific or against a certain individual or a group, but as part of the diversity training, or at least identifying or bringing somebody in to highlight some of these stigmas and issues, to identify perhaps blind biases that people are implementing, because some people don't understand that they even implement that. Like,
Yeah.
somebody in their 70s or 80s don't even realize perhaps maybe they are saying, like, for you, that this woman might be not be able to lift my leg. I'm a 6'8" guy and I have a 300-pound leg or whatever. And so it is part of it trying to bring that in and identifying biases so people understand that they are aware of them.
Oh, for sure. There's, bias training. We can't talk about what we're talking about without talking about bias training, which is a whole separate conversation, probably
Yeah.
for a whole different podcast. But a lot of this stems from bias, the implicit biases, and then the ones we know and the ones we don't know.
Right.
And training, at least the trainings that I've been in, it can be difficult to face your biases, and I think we all have them. And so looking at that, that could be a potential barrier to sort of improving the system and diversifying the profession. If you're faced with your own bias and it makes you uncomfortable, you're going to run away. Leaning into that discomfort, I think, is crucial, not just within the context of yourself as an individual, but when you look at it in the context of society, and as a clinician, as a manual therapist, as a pediatric specialist, within a larger umbrella, I think that is a really good way to face your bias. And a little defensiveness, I think, is okay. I think it means that you're coming to terms with something that makes you uncomfortable, but
Right.
if it doesn't make us uncomfortable, will it really ever change, right? So bias is key.
And I think it's a great point where we could all find common ground, because we all have biases, right?
Mhm.
Like, if we all have biases, we all can kind of be empathetic to one another and be like, oh, I didn't realize like this is happening, or, and so
Exactly.
on. And it may be an area where we call kind of come together, like, listen, we're all humans here. We all, go through life and we all have experiences. And then at some point you're going to realize, like, damn, I didn't understand. I didn't know that I was thinking this way, or perhaps unconsciously doing this.
Sure. Yeah. I mean, we give each other grace when we learn about our biases. And, I can learn from what yours are, Mike, and you can learn from what mine are. And
Right.
then in having that conversation, we just increase awareness in general that, hey, we have these. And whenever the opportunity presents itself again, we're just a little bit more aware. And I think that's great. That's where it starts.
I couldn't agree more. And we're talking about clinicians experiencing diversity, but also for patients. It's really important. I believe it's really important for patients to see diversity. And do you feel like a more diverse population of clinicians would be able to allow for better health outcomes within physical therapy or perhaps other healthcare spaces?
Yeah, it's tricky because I think as PTs we love quoting research and evidence and sort of backing up these statements with facts and objective data. And so I sometimes at conferences I'm seeking out these sessions where I have my bias in the information that I'm looking for in the studies, which is there's a disparity in outcomes. Patient satisfaction scores are lower if there's discordance between the provider and the patient. There's not much out there, believe it or not, that either that corroborates that story. But there's not that much research anyway about this specifically.
Mm.
So it's tricky. It's sort of anecdotal. I think it's all based on all of our experiences, and what patients have said to me is you're the first therapist who's ever listened to what I'm saying. That could as well be for a white male PT. It doesn't necessarily, even if it's a Black female patient telling me this, can we attribute that directly to race? Maybe, maybe not.
Right.
It's something that I find is probably difficult to measure. It's hard to get rid of bias, even in studies like that, because you're looking for confirmation bias. You want to see what you're expecting, and so the outcomes, we should probably just continue to look into this. I want to believe that there may be a little bit of a difference based on either race or gender or some other category, but I can't say it with confidence because, again, there's not much to kind of back up that statement, but I think we're all aware of it now. So it could be an area to look into.
Yeah, I can't imagine trying to be a researcher trying to identify or get like actual objective data to be like, this is actually happening, or, and
Mhm.
trying to figure out. And you're getting funding for this too. So you got to make sure that you're using resources in an adequate way. So that way you can actually prove what you're actually doing.
Yeah.
And on the topic of patients, are there also health disparities within minority communities, and maybe a more diverse healthcare workers could help to aid these? I know we discussed that perhaps it's difficult to see,
Mhm.
what type of health disparities exist within minority communities.
Yeah, that's a big question, as you know, Mike. That has a big response, but the one that jumps out at me is, we can look at mortality rates, right? Like it's not so much that this group are more likely to die from a certain disease or disorder, or it's the screening, it's the assessing, it's listening to the patient. I think that when we look at this, it some of the systems, the disparities are almost built into the healthcare system, so it makes it a little bit harder to identify specifically where this disparity is birthed. So, we look at normative values, right? I learned very recently from a colleague that the data that healthcare workers use to identify when someone is maybe appropriate for treatment or when the insurance company will actually reimburse for a certain treatment, there's bias within those more normative values. And so that's a little bit scary, because where do we begin? We need to reestablish normative values, right? That is no
Easy
simple
task.
task.
Yeah.
Yeah. So it's easy to kind of make a general statement about the disparities, but looking into how to really dive into them and identify where it would make the most sense to direct our efforts in the healthcare system, I think that would be key.
And it's great that you're at a institution where you're going to be allowed to start working towards this foundation of physical therapy and foundation of healthcare.
Mhm.
And you're in the academia space now, but prior to academia, you were in clinical care. Um, What have you seen were the biggest differences in regards to academia and clinical care, would you say?
Ooh, yeah. So I answer this cautiously because again, I'm kind of new into academia, but I think you can look at it from two different perspectives. So in terms of patient care and outcomes, and just quality of care, I think when you're as a clinician, you are focused on your practice, and because the patient is directly in front of you, it's sort of in my opinion, it kind of changes where your priorities lie in terms of where you're directing your efforts toward, maybe even professional development or whatever the case may be. And in academia, I'm a little bit more removed from direct patient care. So in my opinion, it's almost like there's an extra step to kind of look toward that to get the same sort of drive to trying to word it carefully to look at specific interventions, right? I'm so focused as a clinician on what am I doing for the patient, modifying treatments, and in the moment, sometimes between sessions. Now I think that being a little bit away from it, and of course, being in the clinical education department of academia, my focus is toward getting my students in before they get out to clinic to get ready for what they're going to see in clinic. So it's a little bit tricky, finding a way to sort of remain in touch with what's going on by strengthening that partnership with our clinical sites and touching base with what practice looks like, and then sort of bridging the gap for students to enter into clinic, I think will be crucial for me. But it's early to say. This answer might change next week or next month. So we'll see.
Well,
We'll
moving
see.
opinions are always the best kind of opinions, right?
Exactly.
And
Yes.
I want to build off what you were saying there, because I as a clinic, running a clinic, or being a clinician, a staff clinician, you are worried about making sure patients are doing, or you're doing the best that you can so patients get better. But let's say you're a clinic owner, and not only are you worried about patients getting better, you're also worried about running a clinic, building a team, and all the other things that are associated with running a successful business, so to speak. And so that idea of academia, or the things of quality of care, may start to go to the wayside a little bit, just because you're like, okay, I need to keep the lights on. If I don't keep the lights on and keep things running, then
Yes.
no one gets treated whatsoever.
Exactly.
So I
Yep.
can imagine that's going to be a continued issue. And do you think that some of the pressures within the government, and also just like reimbursement rates on the insurance companies, has this started to put pressure on quality of care, or maybe a turn away from
Mhm.
considering academia within clinical practice? Or do you and just
Mm.
worried about keeping the lights on? Or does that make sense as a
It
question?
makes perfect sense. Yeah, I totally understand what you're saying. And if I'm kind of thinking about it incorrectly, let me know. But there's a business management side to being a PT, whether you're the business owner or the hired clinician to see patients. Where I did work before as a clinic director, these responsibilities did fall on me, right? So I was completely aware of metrics and quality metrics and quantity metrics, like, and how to, not compromise the quality of care based on the quality of or the quantity of patients that you're seeing, and then carrying this over into my student learner who is observing the reality of practice. And so I really I love that I've had my clinical experience and can bring it into academia, because I think sometimes students will come in and they'll come in sort of appropriately ignorant to what the reality of being a practicing clinician looks like. And so kind of warning them and making them aware that there's so much more to patient care, and the balance of too much of your energy into administration versus patient care. It depends on your role and understanding your role within the organization. So obviously the business owner generally will carry more of the administrative weight. If your hired staff member is feeling the weight of your administrative burdens, it may be time to kind of step back and look broadly and say, okay, something's got to shift. For a period of a month, we may have to dial back the number of double booking that we're doing, just to ensure that the practice doesn't fold. So it's definitely complicated, I think, but kind of like we talked about diversity, just being aware, I think, is the first step so that you're not sort of blindsided to the reality of, hey, the world outside of PT school is so diverse. What am I going to do? The world outside of being a practicing clinician is diverse in terms of your responsibilities. Being prepared to tackle either or, I think, is going to be really important.
And do you think the solution, I know you said you kind of try to prepare students and say like these are the realities of the clinic, but do you think it's telling them beforehand to prepare them, or you think it's like putting them in deep water and seeing if they
Yeah.
survive to for them to learn? Because I think if you
Yeah.
came to me as a student, be like, there's going to be so many things that you're going to need to understand as a clinic owner, or, you know, a practicing, you know, clinician, I'd be like,
Sure.
okay, cool, man, I'll figure it out when I get there.
Yeah.
But do you think part of that is actually getting out in the clinic and understanding like, okay, wow, I didn't understand how many different things we have to balance?
Yeah, absolutely. I mean, that's the purpose of clinical experiences. Here we go. You know, it's looping back to ClinEd. It's clinical education bridges that gap, regardless of where the student is placed. They're getting that experience one way or the other. And you know, we'll in a couple of weeks here, we'll welcome back one of our cohorts who are coming back from clinic, and I'm really excited to meet with them and just listen to their experience. And you know, but I've gotten a couple of emails where they've been enlightened in terms of what they thought clinic would be and what it really was. And so, yeah, it's a matter of getting in there and doing it. And that's what clinical experiences are for. It's the exposure to practice.
For those not familiar with the whole idea of clinical care within graduate school, maybe just perhaps describe that and
Sure.
how, you know, various PT programs are run.
Yeah, that's a great question. There are many, many programs and many more starting. Each program obviously is going to be different based on how they map their curriculum. For a couple of years now, I think we've seen a shift towards clinical experiences, which means either full-time or integrated. Some programs have integrated clinical experiences where the students are in clinic 1 day a week for a number of weeks, either independently or in groups. So there are different ways to approach integrated clinical experiences. Some programs have only full-time clinical experiences. So students are in the clinic full-time, Monday through Friday or Saturday or Sunday, working the hours of their clinical instructor, fully immersed in the clinical setting. Obviously the difference between the two, if you're in the integrated, and I've had students in this model where they're not getting the continuity with monitoring the same patient by the time they come back sometimes, depending on the setting, the patient's been discharged. But it is, in my opinion, it's better than nothing. It's some exposure to the clinic world before they go into their full-time clinical experiences. And then whereas your full-time clinical experiences, you're fully immersed, following patients closely. Your clinical instructor is directly supervising your activities, giving you feedback. I think there are pros and cons to each model. And obviously most programs have both. So I think ultimately it's just preparing students for practice and of course taking the board exam.
And how are students matched with various clinicians throughout the country? It's very common for students to go to various areas within the country, just outside of the state alone. I mean, for me, even I went to school in Buffalo, New York, and I did clinical education in Florida as well as North Carolina. So I guess how do you place students into various locations across the country?
Yeah, same. So the placement process itself is changing. The Academy of Education is looking into this. There's a task force. So I think we could probably stay tuned for some different process shifting. But presently, you know, kind of like you, Mike, when I was in school, it was done completely differently. We drew sites out of a hat, you know, and that was that. There was no discussion. Other programs I know have a system. So obviously we've evolved with technology. There are platforms that can assist with different algorithms to match students to sites. So I know that's one way that it's done, which is great, eliminating bias. You know, and to my knowledge, some programs, the students have the opportunity to express interest in certain sites. And if those sites are available, then they get them. If there's competition between students, sometimes there's an application process or an interview process. It's nice because there's a diverse way of doing it. There isn't one way. I'm sure a level of standardization would be helpful for efficiency for clinical sites. But on the academia side, I know that it just varies based on the program.
You had mentioned that some of the students had messaged you after getting their first experience or taste, or maybe a new perspective on a clinic. What are some of the reasons as to why maybe students don't complete clinical or have a bad clinical, so to speak? Like, are they messaging you and saying like, hey, I don't know what's going on here, but I didn't have a great experience and so on. So like, what are the most frequent reasons you see students not completing or maybe having an unsuccessful clinical?
Oh, Mike, the hard questions.
Yeah.
I will not answer that question as a clinical director of clinical education yet, because I am green to it. It's only been a few weeks, but I can definitely answer that question as based on my experience as a clinician. I have most of the time, we have issues with students completing rotations. It's a behavior, professional behaviors, we call them, or unprofessional behaviors. Unfortunately, they're called soft skills. There's nothing soft about professionalism. It can jeopardize patient safety. It can make colleagues feel uncomfortable. Lots of potential impact of lack of professionalism other than not finishing your clinical. We have to consider if the student is hireable. You can pass the board exam, be unprofessional, and then become a liability to patients and the profession. So I will say in my experience, it's rare. I would say obviously the majority of students do well, get through clinic. Coaching moments for professionalism is helpful. It's always a shame sometimes when the clinical instructor may not recognize the moment for, refining the student a little bit. But I think once you recognize that there's a conversation to be had about maybe nonverbal skills or, interpersonal skills that affects patient care, it should be addressed. I think at least for me as a clinical instructor, when I had students early in my career, I would hesitate to talk about it because I didn't want the student to feel like I was picking on them or I didn't like them. And so learning different ways to address this issue is important. This is not a promotion, but taking the the credentialing courses through APTA for me, both courses it was just incredibly priceless. There are specific segments and documents and assignments that you can use to practice how to engage in this conversation with students. So there are definitely resources out there, but professional behaviors are crucial, I think, to passing or failing a clinical.
And you think part of this forward movement towards perhaps better clinical experiences is matching students with professions who are able to push them in boundaries maybe they're not familiar with, or perhaps it's just identifying biases earlier on? I guess, like, what speak to that, and what would you say?
Yeah, I alluded to it a little bit where I hinted at, if you're uncomfortable, it could be good.
Right.
If depending how the student selects their site, how much input they have, I think is uh, having a role in clinical education, you may identify students who could benefit from being pushed. And so that warrants a conversation that says, hey, have you considered looking into maybe this geolocation for your clinical experience? Because you know that it may cultivate a professional growth, especially in professionalism, or just immersion in a different cultural setting, environment. I think that just being aware of getting to know students and then knowing kind of who to push one way or the other, keeping in mind we don't want to compromise potential CI student relationships with clinical sites, and of course patient care. So I think it's a tricky balance.
And how do students navigate when they perhaps go to a clinic and the clinicians are maybe being not incompetent, but perhaps they're doing something that may be a little sketchy, in a way, to put it lightly? How do students, best prepare themselves for that? And who should they reach out to, or what should they do in those instances?
Yeah, clinicians never do that though, right, Mike? Like
Right.
that
Yeah. Yeah. They're
never
always
happens.
gospel.
We're always perfect.
Yes.
Yeah, that's a great question. I obviously it probably happens pretty frequently. I do not speak from my own personal experience in this role, but in conversation with students while I was in clinic, I will say that in hindsight, students mentioned that they don't bring it up. They're intimidated by being in that environment where this person is determining my grade for the course. So I'm not saying a word. I'm going to get through the clinical experience and then just hope for the best. I can argue for both sides, right? Because the student, if they're not comfortable, I think they should know that they can reach out to their clinical education director and have this conversation. And it's an exchange that says, hey, are you comfortable if I don't address it? Are you comfortable if I do address it? This is the student asking the director and say, how do I approach this issue with my CI? And a lot of times it depends on the issue and the severity of the issue. There's a lot at stake with addressing certain things as well as not addressing certain things. So I don't have a really good answer to that question. It definitely happens. I think the biggest thing is knowing that there are resources, whether people resources or just, you know, Googling things on the APTA. There are a ton of resources on APTA on how to have crucial conversations. So yeah, it's a tough one to answer, I must say.
Well, we've been talking kind of the negative aspects of clinical, and I would like to highlight maybe what are some of the things that you tell students. I know you're new in your role, but maybe what are some things that you have told students or you've seen that will allow for students and clinicians to have a successful clinical with somebody underneath them or you interacting with a new clinician?
Mm, yeah, that's a good question. I think it would be just to remember that we're all learners. At no point does one person know everything. And you can learn from someone who is, you know, a student or a PT tech, or, you know, just kind of remaining humble and remembering that there's probably a learning moment as a student in almost every moment you're in clinic, and to remember as the instructor that there's probably a teaching moment in every moment that you're in clinic. It sounds like an oversimplification, and but that's really the reality. Is the first day is just remembering you are here to learn. There are pearls and things that as the student you can bring to your clinical site. That's the beauty of clinical education. And it's reciprocated. The clinical instructor understands that they are there to impart this knowledge and their experience on the student, but be open to learn from the student. There are really skillful ways of doing both and approaching both, but keeping that in the back of your mind, I think, is incredibly helpful.
And part of going through clinical care as a student is to prepare you for, well, clinical care. And
Mhm.
sometimes, we get so focused on passing the board exam and, focusing on that in general, just because that's what the licensure process is like. And how can students best prepare for life after the exam? And how can they perhaps get themselves in a good position to be a good clinician immediately out of school? I know, you want to get as much experience as possible within graduate school, and so that way you can prepare yourself. But what are maybe some ways to ensure that you're going to be best prepared after school and after your clinical residencies and so on?
Yeah. Well, I don't know. I think that it goes many different ways. Soaking up the knowledge from your clinical instructor is helpful. Obviously, not just for learning psychomotor skills, but life skills. So, kind of reminding students it's okay to ask your CI how they became who they are. Learning about people's journeys, I think, is helpful. Just having those conversations even before graduating. And there are conferences, attend conference, network, ask your professors who they talk to when they have questions about certain things. Tapping into all the resources that are available in physical therapy, I think, is just something that as a student, you're so focused, like you said, on the exam that there's a tunnel vision that sort of blocks out everything else that could be actually really helpful for passing the board exam. So, connecting with resources, I think always sets you up for success after school. There's so much to gain from clinical experiences outside of skills, practice skills that I would want to sort of redirect students to consider really talking to their CI about their personal journey. There are so many resources out there now that it makes it a little bit harder to kind of just have tunnel vision. There's this podcast, right? The Health Me podcast. Listen to what people are saying. Books have been written about how to be successful after school, after graduation, early professional, joining special interest groups within APTA. There's so much out there, Mike, that I think, yes, focus on the boards and pass the boards, but don't forget about all the other things that might help you get there.
Well, there is, I feel, a growing body of students or maybe just early clinicians who are saying, like, I don't feel prepared. Where do you think this is stemming from? Is this because maybe students are focusing too much on the academia side of things? Are institutions perhaps not preparing their students, or maybe they didn't focus on things enough? I guess, where do you think some of this is coming from?
Gosh, yeah, that's a good question. I know I felt that way after school, but I felt my institution did beyond more than they were supposed to do to prepare me. So
Right.
it depends. I think that there's probably a hint of like an imposter syndrome that is probably normal after going through such a rigorous program where you're sort of relatively sheltered from the real world, and then it's like the veil is pulled back and now you're faced with bills and paying your loans back if you have loans, and there, and that's the life part of it. The clinician part of it is you're out there on your own. There's no clinical instructor. Like, that is scary, and that should be scary. And I think it's almost more scary if a student comes out and says, I got this. I'm good. I need nothing, right? It's a little bit of that insecurity, I think, is what drives you forward as a new grad to connect with your networks and continue to focus on your professional development. I think it's normal. I will say I think it's normal. I don't know that the blame is necessarily, not that there's blame truly, but I don't think we can relate it to the didactic preparation or the quality of the clinical experiences. Sometimes yes, but overall, I think coming out of school, there's this sense of not knowing what's happening, and that's okay. Lean into it, but then move forward.
Yeah, and I think it's super difficult, right? Because as you see patients, you realize that there's so many working variables that really go into clinical care. And we had discussed this earlier. It's not only just like identifying which ailment somebody may be seeing, but it's also understanding like psychosomatic issues. There's chronic pain, there's so many other factors that go into clinical care. It's like, how do you get that all in 3 years? It's almost impossible, right?
Mhm.
So it's like, how do you make sure that students are best prepared? And again, it's making sure that they're ready for the exam and making sure that they get as much clinical experience as possible. But I guess, how are you measuring, or like, how would you measure preparedness for students as they go out into the world? Like, are we measuring them along the way to make sure no one's falling behind? I guess, like, maybe describe how we understand, or at least know, that students are going to be ready for next phases or clinicals and so on.
Yeah, that's a great question. Gosh, so many great questions. There's almost never really a way to know for sure. I think having systems in place kind of periodically throughout the curriculum, checks and balances, clinical experiences are great. There should be probably a screening method before students go out in clinic, just to make sure that they will be successful, because you don't want to set up your student to fail in clinic either. So I think there are probably checkpoints that can be somewhat scheduled at critical points in the learning process to ensure that students themselves are confident in going out into clinic. But then, of course, you pass the board exam and you feel so good and you're confident that you can go out and practice. But then the first day of work, you're maybe back in that place of confusion. I'm not ready. I think there are probably a whole bunch of different ways that we can assess students, whether it's practicals, simulated practicals, while they're in the program before they go into clinic, just to see if they can either talk their way through it or, process critical reasoning is important. So there are ways to kind of marry that, I think, into the program before they come out into the clinic feeling completely unprepared. But again, I think feeling a little bit unprepared is normal. But remembering that you have been truly prepared for the profession. Passing the board exam is crucial. So
And if you're also a patient listening to this and you're like, what do you mean you guys aren't prepared? It's like, we are prepared. We do understand and we are ready to treat clinically after graduation. Is just much like anything else. You're starting a new job, or if you're, doing anything in life, the first couple months, the first year, it's just trying to bring it all together to make sure that you're providing quality care to patients, and you are dealing with another person's plane of care. You're managing someone else's life in some aspects, because they've been in pain for so long, and so you want to make sure that you're doing a good job. And part of this is making sure that students are prepared, and this is what you're doing, is making sure that throughout their process they're going to be being successful and making sure that they are prepared for life after graduation.
Definitely.
And also part of this, obviously you all live in a COVID world, and I guess, how has COVID changed the way clinicals are done with students, and, what are some of the things that you're seeing?
Yeah, that's a good, I will say that the last couple of years in the clinic have been challenging, interesting, a learning curve for all of us. The students, I don't know, the level of resilience probably required to go through a program like PT school during a pandemic. So kudos to the students. I will say the biggest difference that I saw with readiness for clinic was just, students coming out into clinic after the pandemic, they seemed a little bit cautious, a little trepidatious to approach patients and talk to patients, even touching patients, there was a little bit more of caution is the word that I will use. Of course, recognizing that within the context of the world, for me as a clinical instructor, was important. It's easy to sort of say, well, just get in there, just ask the question or just touch them, just measure the joint, but for me, it was a learning process because I had to pull back and say, what has my student been through? Just kind of meeting them where they are and saying, okay, me as the instructor, I would have to kind of shift the way that I teach my student and maybe give a little bit of attention to the psychosocial aspects of care, knowing that my student has the knowledge to apply it. It's just ask them how they're doing today. That might make you feel better about if you should touch their arm or if you should not. The subjective interview was a little bit shakier because the world was on Zoom. And so now you have a patient in front of you, a live human, who can see your entire body and can read your body language. It's not like you can be business up top and then pajamas on the bottom when you're in clinic. So that, I think, was a learning curve for students, but also for myself.
I think it's a great way to put it. Business on front and pajamas on bottom might be the Zoom mullet. I think we can call it that from now on.
It's there, but you can't see it.
Exactly. Well, I'm curious to know if you're, as a clinical instructor, I mean, this had to been all new. It's new for the students just being in COVID, but like, what things did you experience working through COVID and so on? Were there barriers that you had to overcome as a clinician, working on Zoom, or maybe progressing back into manual therapy and so on?
Yeah, every moment of treating every patient. I am a manual therapist, and so the 6-foot rule didn't apply in the clinic. There were patients who needed, manipulations. They needed close contact. And so it was essentially a risk every time, but it was a risk obviously worth taking to make the patient better. I will say specifically, cervical techniques. I hesitated a little bit because it was, yeah, I'm just in that zone of danger. And so, I would keep my mask on, make sure patients had the correct mask on. It just added another level of screening to kind of use a PT word, to gauge if a certain technique was truly necessary given the risk that I was going to take, or if there was another way to approach, if there was a different way to position myself, maybe behind the patient instead of directly in front of them. Can I do this technique in prone instead of supine? There was a lot of mental questions and answers that was happening in the moment, something that I had never thought about. I just leaned in there and did whatever I had to do with the patient. For me, it caused me to step back a little bit. And so that's part of why I felt like I could empathize with the students as well. It's essentially the same struggle.
Was part of this mental gymnastics maybe an experience that made you a better clinician?
Oh, absolutely. The beauty of PT is how creative we get to be with a lot of our treatments and assessments. And so having to kind of tailor it to a pandemic was no different. You just had to get creative on how to do what you needed to do. There was the risk of treating a patient closely and then the next day they call out because they were exposed to COVID. And now you're treating your next couple patients with this fear of, do I have it? Am I going to give it to my next patient? While you're still trying to do the other things like manage metrics and teach your student. And yeah, it's mentally draining.
I can imagine it was, and kudos to you to work through that, because I can only imagine what it was like.
Yeah, it was tough, but we got through.
Absolutely. And I was going to ask, and even as a new practicing clinician, I've been out about 2 to 3 years now. I, I'm been posed the question like, well, maybe should I take a student at some point in my career? And when should clinicians start thinking about this idea of like taking on students, and should all clinicians even see students?
Yeah. Oh, that's another one that I could probably talk about for hours and hours. I have a passion for clinical education because I had really good clinical education leaders when I was in PT school and wonderful clinical instructors and mentors along the way. So this question is being answered transparently with a lot of bias that I completely own. Um, I think there's a level of, you have to kind of be introspective on why you're taking a student. So looking at motivating factors for wanting to be a clinical instructor, are you wanting to essentially give back to the profession because someone did the same for you? That's kind of a nice intrinsic reason to want to be a CI, absolutely. Do you want to do it for CEUs? Sure, why not? We need them to keep our license. But weighing out all your motivations for wanting to take a student, I think is important, keeping in mind that you're shaping the future of our profession. So it's not something, in my opinion, to be taken lightly, but every PT should have a student, for lack of a better way to put it. There's Personally, it's really enriching to be able to learn from students and to know what you don't know sometimes, even as a clinician, things I've forgotten because I've been out practicing. Students kind of remind me of these things. It's a way to stay engaged, obviously, in the profession, to grow yourself, professionally, and then just being a mentor is so rewarding in so many different ways that I think if we were to pick a number, I started taking students after a year of practicing. I would obviously sort of recommend some time practicing, kind of getting into your groove as a clinician. A year or two seems to be like the sweet spot. But I mean, I don't know if that's something that's been studied. At what crucial point would the outcomes for students be better if the CIs practice for so long? So yeah, I mean, I'm all for clinical education. I think you should have at least one student, feel it out. You'll probably love it and just keep having students multiple times a year. It's incredibly rewarding. I highly recommend it.
Well, what are you most excited about next? I'm really interested to hear this discussion. I know we talked about diversity, we talked about clinical education. You started a new role as a clinical educational. So I guess, like, what are you most excited about next?
Gosh, so much. Definitely just learning the role at this point, and all the different moving parts to clinical education. And then being surrounded by students a little bit, even more than being in clinic. Now there are many more students who bring so much to the table. I'm really looking forward to kind of getting the basics down and then pouring into students and having them kind of return the favor and teach me all kinds of things, and learning about their experiences, understanding what they're going to bring to our patients once they're practicing clinicians. So I'm excited about a lot of things, but I think those are the top two.
Always learning, always striving. I
Yep.
admire everything that you're doing, and I really appreciate you coming on the podcast today to share everything that you do and you're passionate about. Last part of the podcast is coming up, and this is the Health Me to Health You portion of the podcast. Gave you a little bit ahead of time to look at these questions and think about them and how you're
Yeah.
going to answer them. So first question is, if you had the attention of everyone in the world for 30 seconds, what would you say?
Yeah, my response will not take 30 seconds. It is that I would encourage everyone to share your experiences through storytelling. You will likely amaze yourself and you'll likely amaze others. That is it.
That's how we communicate, right? Storytelling and making sure that, we're listening to one another. I couldn't agree more. Second question, what book do you recommend, whether a book you're reading now or in the past?
Yeah, I have two really big ones. And I think I've said this on a different platform, is the one book that has been life-changing for me is Napoleon Hill's How to Own Your Own Mind. Gosh, I could talk about it for days, but everyone should go and buy that book. And currently I'm reading 13 things that emotionally strong people don't do.
Not what they do, but they don't do.
Yes. It's a good one. It's by Amy Marin.
I'll have to download it on my Audible. I'm not a great reader. I usually, and not that I can read fine, but I feel like I digest information better through audio. So I'll have to put that on my list.
It's wonderful.
Last question. Where can people learn more about you and what we talked about today? Everything will be in the show notes, but I just want, you can put it out audibly. So if people are just listening.
Yeah, I found a lot of resources that I lean on and that you can as well on the APTA's website. You can either go on apta.org, Google diversity, Google DEI, search that on the website, or you can go, there's a website and I'll kind of rattle it off. It's apta.org/apta-and-u /diversity-equity-and-inclusion. So it's probably easier to go to APTA and just search diversity, and there's a ton of information out there.
Where people learn from you if they want to follow you anywhere?
Yes, you can follow me on Twitter, Moyo Tillery DPT, or you can find me on LinkedIn. Just type my name, Moyo, Moyo, last name Tillery, Tillery.
Thank you so much for coming on the podcast today. I really appreciate it.
My pleasure. Thank you, Mike.